Good afternoon. I think that it's time that we start. I am supposed to talk today about wavefront and refractive surgery. I will make an introduction of refractive surgery. It will be about a time traveling since the very beginning of refractive surgery to nowadays techniques. And in that way, we could understand better about the wavefront. Of course, I have no financial disclosure. Sorry, I don't have any financial in these products. Okay. The refractive surgery could be divided in keratorefractive surgery when we act over the cornea, or phacorefractive surgery when we do it on the crystalline lens. Also, we have to differentiate from now on the refractive errors with low-order aberrations, which are myopia, hyperopia, and astigmatism, and high-order aberrations that so far we didn't know. So until just a few years ago, we discovered the high-order aberrations, and there are about 30 or more other refractive defects inside the eye that were not detected in the past. What are the principles for refractive surgery? We can relax the cornea. We can add corneal tissue or other materials to the cornea. We can subtract corneal tissue, which basically is what we are doing today. We can modify the corneal tissue, or we can compress. So we just need to change the corneal shape to correct abnormalities of the curvature. Going back to the very beginning in the 17th century, the first description of refractive surgery were from Snelling, Schotz, and Lanz, that they did some relaxing incisions to correct astigmatism. Tatsuo Sato in Japan in 1939, he started doing radial keratotomy. Okay, but the problem is that he did it in the endothelium with a special knife that he designs called the kamokuto. So he cut all the endothelium, and he didn't realize that he was decompensating those corneas years later. Arturo Malbrán in Argentina in 1953, more than 60 years ago, he started doing radial keratotomy in the anterior surface. And Genaliev in Russia started with the modern radial keratotomy. It was Stanislav Fyodorov, who industrialized the radial keratotomy to correct or to solve medical problem that they have, an economical problem. Leo Boris is the one who introduced the radial keratotomy to the United States in 1976. The difference between the Russian and the American technique, both, they used only two parameters in the normograms: the age of the patients and the amount of myopia. And depending on these two parameters, they use larger or shorter incisions, and also they changed the number of the incisions in the anterior surface. The difference, the Americans did the cut from the center to the periphery, and the Russians cut from the periphery to the center. This is the operating room that we had in our clinic in the 80s and beginning of the 90s. We did about 14,000 radial keratotomies in the country. Also, we have the astigmatic incisions, which length will depend if it was a compound astigmatism, if the spheric equivalent was negative or positive. Then the father of the new refractive surgery is Jose Ignacio Barraquer in Colombia, which in 1949 he described the law of thickness. Also, we have other surgeries, as the epikeratophakia from Dr. Kaufman and Werblin in 1983. Then Luis Antonio Ruiz modified the original keratomylosis from Dr. Barraquer to the automatic lamellar keratoplasty, which is called the keratomylosis in situ. Srinivasant, Awad, and Trokel in 1984, they came with the Excimer Laser, but the Excimer Laser at the beginning was not used to do lamellar ablations. It was to reproduce radial keratotomies, so replacing the diamond knife with a laser. Theo Seiler in 1987 is the one who performed a PRK in human, and Burato and Palikaris, they described the LASIK in 1991. The law of thickness of Barraquer states that to reduce the refractive corneal power, which is to correct myopia, we should remove tissue at the center or add tissue at the periphery. It is to flatten the central cornea. And the opposite, to increase the refractive corneal power, you have to add tissue at the center or remove tissue at the periphery. There are different refractive lamellar procedures. The keratomylosis, the first one was the freezing keratomylosis, then the keratophakias, epikeratophakias, the keratomylosis in situ, and the modern PRK, LASIK, LASIK, and the inlays, rings, segments, the intracorneal lenticles. And the word keratomylosis comes from Greek. Kerato means cornea, and smylosis is sculpt. So we sculpt the cornea means keratomylosis. And the freezing keratomylosis, Dr. Barraquer's initial procedures was take the part of the patient's cornea, dye it, freeze it, lathe it in a cryolathe, defreeze it, and suture back in the original position. So he removed about 80% of the corneal depth, dyed to differentiate eyes from stroma. In the cryolathe, it was freeze with CO2, and look at this is a positive lenticule, which is thicker in the center to correct hyperopia or aphakia, and then suture back in position. The keratomylosis in situ, it was designed by Luis Antonio Ruiz, one of the disciples of Dr. Barraquer, and he reshaped the cornea in situ. So he didn't need to remove it. Using just the microkeratome, the blades, he passed the microkeratome twice, the first one to cut the disc and the second for the lenticule. So we used, at the beginning, we used manual microkeratomes, then automatic microkeratomes. I went back to the manuals, and with the first ones, you reset at 160 disc parallel faces, and this is the bed. Then changing the plate, and depending on the degree of myopia of the patient, you resect the lenticule. This is disc, parallel faces, lenticule, non-parallel faces. And this is exactly what we are doing today with the Excimer Laser. And then, of course, we needed to mark, so we have to replace the flap back in position, in the original position. At the beginning, we used interrupted sutures, then running sutures, and later we didn't use sutures at all. With compressed air, we fixed the disc back in the original position. Then the epikeratophakia. Epi is over keratocornea, and phakia means optical power or lens, is to place the optical correction over the cornea, or a living contact lens. That was developed by Kaufman, my mentor, and Werblin. So initially it was designed to correct high anisometropias in children or traumatic aphakias. You see, this is the trauma, suturing, and now you see the lenticule, you see the two Baumans over the cornea. And the same, but instead taking part of the patient's cornea, we took a donor cornea. We freeze it and lathe it, and then we remove the epithelium of the patient's cornea, just create an annual keratotomy with Trifine, and with the Suarez spreader do a lamellar dissection, a pocket, to introduce the wind of the lenticule in place and suture back. Initially, it was used for aphakias, high positive powers, but then we start using for negative to correct also high myopias. At the beginning, they were lyophilized, and we also use it as a fresh tissue for congenital or traumatic cataracts. Keratophakias could be homoplastic or alloplastic keratophakias when we use corneal or synthetic material. We're removing a flap, and we can insert maybe this lenticule that we remove from a keratomylosis in situ. This was to correct myopia, but we could use it as in a homoplastic keratophakia to correct hyperopia. Or today that we are using the intracorneal segments. At the beginning, the intracorneal rings were not designed to correct astigmatism. They were designed to correct myopia. Then they evolve for the astigmatic correction. And also, we can use intracorneal lenses, the ICLs, but no ICLs as in intracorneal contact lenses, intracorneal lenticles. And now they are becoming more and more popular with the raindrop or the karma for the presbyopia correction. So also we can use methods to modify the corneal tissue and the thermocoagulation, contact or non-contact with the Holmium YAG laser trabeculoplasty with contact or not contact, but now they are not used at all. Finally, we came with the Excimer Laser, as you saw, the Taboada and Troquel, and the word Excimer comes from excited dimmer gas, as the argon fluoride is a cold laser, no cut, no burn. The principle is photoablation to remove corneal tissue without damaging the surrounding collagen. And the modalities are the PRK, photorefractive keratectomy, phototherapeutic keratectomy, the laser intrastromal or laser in situ keratomylosis LASIK, or the subepithelial LASIK, the LASIK. With the PRK, we just remove superficial corneal tissue. It means epithelium, Bowman, and anterior stroma without creating flap, and let the cornea reepithelize with a bandage contact lens. So superficial ablation. I don't like to use alcohol, but you can do it. You can remove it with the alcohol and do the photoablation. This is a flying spot laser. Clean it. We didn't do PRKs for over 4 diopters of myopia or aesthetic equivalent, so we usually didn't use mitomycin. But one of the complications of the PRK is the haze. This is for a myopic treatment or for hyperopic treatment, especially in black people. The LASIK is a resection of a superficial corneal flap, preserving epithelium and Bowman and some superficial stroma, and then creating the lathing with the photoablation with the Excimer laser, and reposition the flap back. So creating the flap, at the beginning we tried 150, 160 microns flap, then the ablation, and put the flap back in position. In the early 2000s, maybe 1999, 2000, I asked the company to manufacture a 100 plate in order to save more corneal stroma. I'm sorry. So the Moria company manufactured the microkeratome with fixed plate with 100 microns. So that's avoiding ectasias. Manual microkeratomes, and with the flat manipulator, you see that it has just epithelium, Bowman, and a very thin layer of stroma, anterior stroma. Then the photoablation, this is the typical LASIK surgery. And with a Vidauri double cannula, rinse and wash the interface. And with compressed air and a wet cell and a metal cell sponge, I replace back in position, the flap back in position. This is our center. This is Centro Médico Docente de la Trinidad. This is where I work. This is the main building, and this is the ophthalmology, where here is ophthalmology department. And this is a private foundation, teaching foundation, where we did a lot of cases. From 1995, we bought our first laser. It was a coherent shrimp, the keratome. At the end of 1994, we started in 1995, and at the beginning it was not shrimp, it was coherent shrimp, the company associated. And in 5 years, we did close to 40,000 LASIK procedures. It was a broad beam modulated by metallic bands, and we thought that we could correct anything. So we went to patients even over 20 diopters of myopia. We were, bad idea. But, for example, this one, 14 and a half and 16 and a half diopters of myopia and astigmatism. 1 year later, look at the deep ablation, central ablation. And, well, the patients 2060, 2030, after that degree, we thought that we were doing the best surgery. Then we had the multi-scan from 2003, 11,000 cases. It has the first one with eye tracking, but still broad beam and fractal mask. Then the Surgeries. The Surgeries, we started with the Surgeries, and it was the first one which has a flying spot, high frequency, 200 hertz, personalized ablations, because we got Wavefront, and we could detect high order aberrations. At the beginning, we did Wavefront guided ablations for every patient. Bad idea. This is the Wavefront guided ablation. You can see has almost 2 diopters of myopia, defocus, and 1.5 of astigmatism. Now, remember, this is low order aberration, defocus, and astigmatism. From here, coma, trefoil, spherical aberrations are high order aberrations. So in the third knee coefficient, we reduce, and this is pre and post-op after 1 year, much better with the front guided ablation. Also, we had the alternative of topography guided ablation. So these patients, uncorrected, the pre-op, 375 and just a quarter of diopter in the post-op with a topography guided ablation. Finally, in 2008, we got our first Amaris. We got 2 different versions of the Amaris. And these are the 2 laser rooms that we had there. So we come for the refractive defects, the refractive aberrations. And please remember that. You will have a quiz later, and we will be in refractive surgery, the quiz. Low order aberrations, myopia, hyperopia, and high order aberrations. So the low order represents about 80% of the visual defects that we manifest. And so far has been corrected with glasses, contact lenses, or conventional refractive surgery. The high-order aberrations represent about 20% of the visual defect, and so far were not detected or corrected until a few years ago. Those high-order aberrations could be increased with the age, ocular trauma, or surgeries. Which is aberrometry? Aberrometry is a technology which it was imported from astrophysics with the telescopes and the deep space analysis. They got a lot of turbulence with the atmosphere, and they include the aberrometry to compensate that turbulence and get clearer image of the deep space planets or stars. So this is a method to determine the aberrations. The aberrations, as I said, are more than 30 in the ocular optic systems, and today it's possible to compensate with the Excimer Laser, personalizing the ablation with the wavefront. There are different methods of aberrometry. The first one was the Chernin aberrometry, which analyzes directly the image which is formed in the cornea. If you have a cornea deformation in the retina, if you have a cornea deformation here, the image reflected in the retina will be altered. There is another method, it's called the Specially Resolved Refractometer. It's based on echoscopic principles. And the most popular one is the Harman-Schach aberrometry, which measures the emerging wavefront after being reflected in the retina. So the principle is the aberrometer emits monochromic rays of light to the retina, and then they are reflected back as a wavefront, parallel rays, and if the whole optical system is normal, we will get a flat, very regular wavefront. It's a perfect wavefront in the photosensors. But if we have any alteration in, let's say, in the cornea, in the lens, or in the other clear structures of the eye, including the tear film, we will get abnormal wavefront. So the wavefront error is the difference between the real and the ideal wavefront, and this error degrades the optical image proportionally to the pupil diameter. The larger the pupil, the more aberrations we will get. So to define the needed optical surgical compensation, and could be a retarded wavefront when we need to eliminate more tissue, or advanced wavefront that we need to eliminate less tissue. These errors are analyzed individually by the Cernic polynomials. Okay, these are the Cernic polynomials, and they are used to analyze the wavefront error that could be decomposed in different terms, which reveal the partial contribution of each one of the total error, which is the root mean square. Usually, the defocus is the main aberration, which is myopia or hyperopia, followed by astigmatism. These are the low-order aberrations. We don't have here the first one. It's the tilt, then called tip and tilt, piston, and defocus, C4, and astigmatism. Then we have the high-order aberrations, which will have in the third order the coma and the trefoil, and in the fourth order aberration, the most important one is the spherical aberration. So zero order piston, tip and tilt, second order defocus, myopia and hyperopia, and astigmatism. For practical surgical corrections, the aberrations considered for treatment are from second order and below. So from here down, defocus, astigmatism, coma, trefoil, spheric. Usually up to the fourth order is enough, but we have to analyze that. So remember these names: third order, coma, which could be vertical and horizontal, and trefoils. Fourth order, spheric aberrations, which is the most important, secondary astigmatism, quadrifoil, secondary coma, etc., etc. As we learn to analyze the topographic maps, we also need to learn about the polynomials graphic representations. First order, high orders, and to compensate that, we need special lasers, not the broad beam lasers that we had at the beginning, not the scanning lasers. We need lasers with flying spot, and not only flying spot, they need to be a very fine flying spot with high speed. And the Excimer Laser and Wavefront, we need flying spot ablation, advanced and active fast tracking system, high shooting speed, and peripheral system to detect optical anomalies and aberrations, which are the Wavefront aberrometers, and also a very advanced and sophisticated topographer analysis. So after you get the topography and the aberrometry, you analyze that in the software, and that is sent to the laser. What are the modalities of ablation that we have nowadays? We have the wavefront guided, or by aberrometry, which is the one that we use very frequent at the beginning, topography guided by TopoLink, and the aspheric ablation. Right now, when I left, we were doing about 90% of the patients with aspheric ablation, maybe 6 or 7% with topography guided, and very few cases wavefront guided. So we have the two different modalities here: ablations guided by the curvature map or by corneal aberration map. Let's put some examples. Let's say that we have this patient that has almost no myopia, yes, a low order of a quarter of diopter, coma, but has astigmatism. So the point spread function, so that's the imaginary point compared with a normal one, will be like this in this patient. And we can select which of the aberrations we correct. So here is the component of the spheric and the astigmatism, and we said, okay, let's correct just the defocus, the myopia. Well, not much improvement. Let's correct myopia and astigmatism. Well, it's better, but we still have a diffuse point. Okay, now let's go with the high order aberrations. Let's correct the third and the spherical aberration. So now we get a nice sharp point, and you see that is aberration free. Correcting more will not increase the quality of vision, and we could sacrifice more corneal tissue without any necessity. Another example is a patient with 6 diopters of myopia and more than 3 diopters of astigmatism. This is the point spread function, and this is visus. This is like the representation of the Snellen charts vision of this patient. Correcting just the myopia, better, but we still have some unclear image. Correcting the low order aberrations, myopia and astigmatism, even better. Look at how improved. And now correcting the third and the fourth order aberrations, now is clear. We went to the 5th and the 6th order, but without any benefits. This is the typical myopic correction. Let's say this is theoretical for 7 diopters of myopia. See the deep central ablation. This is a patient with a high astigmatism, patient with hyperopia, peripheral ablation, it's a relative central steepening, compound astigmatism, wavefront guided. And this is an example of the same defect with topographic guided ablation and wavefront guided ablation. The wavefront guided takes a little longer. Well, now with the new lasers are even faster. And now we have the femtosecond corneal refractive surgery. First, what is a femtosecond? Femtosecond is a quadrillionth. Quadrillion is 1/1,000,000 of a billion of a second. In 1 second are 1,000 billions of femtoseconds. In 1 second are as many femtoseconds are seconds in 100 million years. So you can imagine how fast is this laser. And with a femtosecond, we can do corneal flap, tunnels, bags, we can do stromal resections, relaxing incisions. This is the new era for the refractive surgery. The speed, okay, of the laser will determine the size and the number of spots that we need to create a flap or tunnels. In this, you can see a very regular flap, and you can control also very precisely the depth of the flaps. There are 2 techniques, flex and smile. Flex is when they do the intrastromal ablation without creating huge flaps. So refractive surgery is a very complex subspecialty. It's not a hobby. It's not a side income. It's not for the occasional surgeon. It's very satisfying professionally and personally. Okay? There are many options of refractive surgery, okay, as you may see in this quadrant, but trying to resume the indications for the keratorefractive surgery, if you are going to consider keratorefractive cornea surgery for the patient, needs to be 20 years old. All the data, those are my personal parameters. Okay? Normal, completely normal topographies, sufficient corneal thickness, especially after the ablation. You have to know what is the residual stromal bed that you are leaving. Dr. Barraquera started with 200 microns, then 250 microns, and now I think that the standard is 300 microns, and especially patients with a stable refraction. For phaco-refractive surgery, for intraocular contact lenses, ICLs, the age between 25 and 45, anterior chamber depth between 3 and 4.5 millimeters, stable refraction, and endothelial cells count now over 3,000. At the beginning, all those parameters has been changing for complications that they have had in the past, but now they consider these parameters as safe. For clear lens extractions, phaco-refractive surgery, 45 years of old for myopia, 35 for high hyperopias, regular topographies, stable refraction, but we have limitations with the IOL powers. Also for the astigmatic correction with the ICLs. For diopters, I know that there are lenses that you can order to correct up to 8 diopters of astigmatism, and this is the limits for the the presbyopia. Refractive defect, the keratorefractive surgery, the limits of the keratorefractive surgery will depend on the pachymetry and the residual stromal bed and the patient's age, and maybe up to 10 diopters of myopia with LASIK. The age, between 20 and 40 years of age with a stable refraction, keratorefractive surgery. Over 40 years of age, if the patient has myopia, if it's a low myopia, you can consider keratorefractive. You can offer monovision for the future presbyopia. From moderate to high myopias, phaco-refractive surgery with ICLs, IOLs, with monovision or multifocal IOLs. The keratometries. Patients with flat keratometries don't consider keratorefractive surgery because you will induce high-order aberrations. This is a patient with 575 and 6 diopters of myopia, but the case are in the 39s. So this is not a good candidate for keratorefractive surgery because the low keratometry values. In hyperopia, the limits in keratorefractive surgery from 20 to 30 years of age, of course, after cycloplegic refraction, I don't do, or I didn't do, more than 3 diopters of LASIK in these patients. And in the last 5 years, I never did a case of hyperopic LASIK. If it's more than 3 diopters, offer just contact lenses or glasses and wait. So don't do keratorefractive surgery in a patient with more than 3 diopters of hyperopia. If the patient is 35 years or older, maybe phaco-refractive surgery with multifocal IOLs or monofocal IOLs offering monovision. The keratometries is the opposite than in myopia. Don't do patients with steep keratometers because you will induce high-order aberrations. This is a patient 45 and 46 of hyperopia, 3.5 to 75. If you do a LASIK surgery in these patients, will end with 48, 49 case, which will be very inconsistent with the quality of vision. Also, we describe regression, not only the refraction, but in the keratometries in the young patients that we did hyperopic correction. Let me show you one case. 31 years of age, wanted a hyperopic surgery. The refraction was 2.5, and the keratometers were 44. We did a LASIK in September 97. In 98, he was 47, and the refraction was planar. In 5 years later, from 47 to 46, and start manifesting some hyperopia. 2 years later, 46, 45, 45, 50, and look at the topographies. 1.5, 125. In December 2008, 10 years after the procedure, 44, 50, 45, very close to the original case and very close to the original refraction. They not only lose K readings, they also lose accommodation and lose the power that was induced in the cornea. LASIK. No, we never did PRK in this case, LASIK. For astigmatism, patients between 18 and 40 years of age, from 1 to 4 diopters, LASIK or PRK, over 4 diopters, don't do keratorefractive surgery, over 40 years of age, phaco-refractive surgery with toric IOLs, monovision, or toric IOLs with multifocals. So the refractive surgery, the surgical success is mainly related with the precise ophthalmological, medical, and psychological patient selection. The chair time is the time that you spend with the patient explaining pros, cons, advantage, disadvantage, and you can choose which is the ideal patients and which is not. So those are minutes expended in a proactive attitude, which could save hours in reactive attitude. Undersell, over delivery. That's the caveat for refractive surgery. Thank you so much. Questions?
Very much, Dr. Suarez. And now for myopes over the age of 40, if they are asking for refractive surgery, instead of monovision, you can go and correct, and then you can fully, and then you can use any of the devices like camera for the reading part of the myope patients. Do you have experience with this? Do you prefer it for over monovision, or you still go for monovision?
When I started doing refractive surgery, I was in the 30s, okay? And I underestimate the presbyopia. And when I did the patients over 40, they said, well, but you will have perfect distance vision and you use reading glasses. What is the problem? Everybody will use reading glasses. After I became presbyopic, I didn't underestimate that anymore. And I started valuing monovision. So I think that you should offer the patient all the alternatives. First one, correct both eyes and reading glasses. Second, monovision, choosing the best eye for distance and the non-dominant for reading, and not leaving more than 2 diopters of residual myopia in the non-dominant eye. The third one will be multifocal IOLs as a third option, or maybe in the future there will be other alternatives for presbyopia correction, as the karma, as you mentioned, doctor. But you have to let the decision to the patient and explain very, very carefully the pros and cons of each of the alternatives you offer.
Do you have yourself a personal experience with the camera? Because now it is
No.
FDA approved.
No.
And this will preserve the binocular vision for distance.
I have asked doctors, honest doctor, that they have used it, and even after hundreds of karmas that they have implanted, they are not completely convinced and satisfied.
Thank you for this nice illustrated lecture. My question is regarding the superficial treatment. You don't believe in it? You're doing only LASIK? Because nowadays many surgeons are shifting from LASIK to superficial treatment to preserve more corneal thickness.
You're right, doctor. At the beginning, I never did PRK. Well, I started LASIK in the 1995, when in Europe they correct up to 15 diopters with PRK, and we have the ghost of the haze, the secondary haze. So at the beginning, I never did PRK. And even for 1 diopter of myopia, I did LASIK surgeries. Then the balance started switching. And in my last years of refractive surgery, maybe 60-70% of the cases were PRK and 30-40% of LASIK. So I switched from LASIK to PRK, but limiting the correction in our centers to 4.5 diopter of aesthetic equivalent with PRK. No more than that. Dr. Harvey?
Venous extraction after like 40 or 45 there's no more condensed power for correction of myopia. You do venous extraction, then you will use monovision. So one of the ideas is to, because not many patients accept the monovision, one of the ideas is just to ask the patient to wear contact lens, so just to try. What is the, do we need neural adaptation for this? So if you wear contact lens for the patient, you need to wait how long so the patient can judge if he's happy with this or not.
Exactly, that's what we propose. We ask the patient to try a contact lens, okay, for if they are myope, or to remove, depending of the degree of myopia, to remove one of the contact lens and try it for 1 or 2 weeks, and then remove the other one and see which one you feel better. If the difference is too high and we just want to correct or leave 1.5 to 175 of residual myopia in the non-dominant eye, we ask to use contact lenses for at least 1 month. Okay, and if the patient, surprisingly, after you explain the side effects and all the inconvenience of the multifocal IOLs, the patients agree, and most of the patients are more satisfied with monovision than with multifocal IOLs. Tariq?
My question is, if the thickness allows you for deeper ablation, what is the lower limit for case for it? So, if you can reach up to 32, would you go for that, given that the thickness is acceptable?
Depending on the degree of the defect. How?
He needs like high refractive, and he needs deeper ablation. Would you reach 32 if the thickness allowed, or there is limits for you that beyond this you will not?
I had to imagine the post-op, the case, and the residual bed of the patient, because let's say that the patient has 600 microns of central thickness and have 7.5 or 8 diopters of myopia, but it's a steep cornea. So if after ablating the cornea, I will have more than 300 microns in the residual stroma, and the case will not be lower than 3940. I think that after that, it's not only the center. It's not only because you are measuring just the center. It's the relation with the central and the mid-periphery. Because you are inducing high-order aberrations if the bottom in the center is too deep compared with the mid-periphery of the patient.
My second part is the lower thickness allowed for you without epithelium. It's like for PRK. It's fixed for LASIK, but PRK is not yet established. What is it for?
For 2450.
Without epithelium?
Without epithelium, and for low degrees, because I don't like to go over 4 diopters with PRK. Dr. Matara?
Dear Dr. Suarez, in your opinion, because we saw the indications of refractive surgery and there are no children there, do you think that there is a role for refractive surgery in children? And if that is the case, do you think it would be more the intraocular surgery than the one that is done in the cornea?
I think that, refractive surgery in children are desperate cases. So when you really don't have anything to do, like high anisometropias, or like you saw the epikeratophobia in traumatic aphakias. So maybe, I think that now we feel more comfortable doing refractive surgery in some children where you cannot do anything else, and you are trying to rescue those patients from the amblyopia. So it's better to do something that leave that eye get blind or get amblyopic. So I think that there are indications, specific indications for refractive surgery in children. But knowing the evolution and the change in refraction, so you have to calculate that. And also, I think that there are some place for the refractive lens exchange in children also. Okay. Thank you again.